Our next presenter is Beverly Kyalwazi from University of Chicago, Pritzker School of Medicine. She will be here in person and will discuss analysis of clinical outcomes and expression-based immune signatures by race in the I-SPY 2 trial.
Good morning. I would like to say thank you to the organizers of the San Antonio Breast Cancer Symposium for inviting me here today. It's honestly a huge honor being here. My name is Beverly Kyalwazi, and I'm a fourth-year medical student at the University of Chicago Pritzker School of Medicine. On behalf of the I-SPY 2 trial investigators, I'm excited to share our analysis of clinical outcomes and expression-based immune signatures by race in the I-SPY 2 trial. I have no disclosures. The breast cancer mortality disparity between Black and white women is well established. Black women continue to be underrepresented in clinical trials. We were particularly interested in the I-SPY 2 clinical trial because it provides the opportunity to look at women with locally advanced breast cancers in the neoadjuvant setting. Our aims were to evaluate whether I-SPY 2 clinical trial outcomes were independent of race. We did that using the following statistical methods. We used chi-squared tests for associations between racial demographics and patient characteristics, logistic regression for pathologic complete response associations, and Cox proportional hazard modeling for event-free survival. Our second aim was to assess variations in immune-related gene signature expressions as a predictor of pathologic complete response. We did this using analysis of variance in 2 key tests. The following is an overview of the current I-SPY 2 trial study schema. Women with stage 2 or 3 breast cancers at high risk of early recurrence are randomized to receiving either standard chemotherapy alone with paclitaxel followed by anthracycline, or standard chemotherapy plus one of the investigational agents. At set time points throughout the trial, women undergo biopsy, imaging, and blood sample collection, allowing for investigation into potential prognostic biomarkers and the association of these biomarkers with patient demographics and clinical outcomes. Currently, there are 26 active I-SPY 2 clinical trial sites. The broad distribution of these sites across the country was one of the motivating factors for us in conducting this analysis, especially given the disparities in enrolling diverse patient populations in clinical trials today. The following agents and agent combinations have been evaluated in the I-SPY 2 trial to date. Our analysis included 990 patients who were initially enrolled in the trial. These patients were randomized among the following first 10 investigational arms of the trial. Their median follow-up was at 4.4 years. Of the first 990 patients enrolled in the I-SPY 2 clinical trial, 16 were excluded from our analysis as they identified as part of a racial group with less than 10 patients in the trial. Our pathologic complete response analysis included 974 patients. 67 of these patients were lost to follow-up, and our outcome analysis of event-free survival consisted of 907 patients. The following is an overview of patient baseline characteristics. Racial demographics were self-reported, and 81% of patients identified as white, 12% of patients identified as Black or African American, and 7% of patients identified as Asian. We also had data on patient ethnicity, but did not include it for this particular analysis. The median age of all participants was 49. We looked at breast tumor characteristics, including SBR grade and residual cancer burden class. There are no significant associations between these characteristics in patient racial groups. We also looked at blueprint molecular subtype and the association with self-reported patient race. Though Black patients had a higher percentage of basal breast cancers, the distribution of basal, HER2, and luminal breast cancers did not differ among racial groups. Our primary endpoint was pathologic complete response. Pathologic complete response was not significantly associated with self-reported patient race. The number of responders in white patients was about 30%, as well as Black patients and in Asian patients as well. Our secondary outcome we looked at was event-free survival. In the overall population of women, there are no significance in event-free survival by patient racial groups. We went on to look at event-free survival in the context of achievement of pathologic complete response. On the left are survival curves of patients who achieved pathologic complete response. In looking at survival outcomes among these group of women, there are no significant differences in survival when pathologic complete response is achieved. However, when pathologic complete response is not achieved, we see significant differences in event-free survival. Particularly, patients that are Black or African American have significantly higher rates of recurrence or mortality than white patients. The hazard ratio is 1.61 and p-value 0.003. To further investigate, we looked at patients who had residual disease, and we stratified these women by their receptor subtypes. We looked at the following 4 receptor subtypes, and in particular, women with hormone receptor positive, HER2 negative breast cancers who did not achieve pathologic complete response had significant differences in event-free survival by racial groups. In particular, Black patients had almost twice the rate of recurrence and mortality than white patients. The hazard ratio was 1.95 and p-value was 0.04. We looked at 3 other receptor subtypes. In triple-negative patients who did not have pathologic complete response, we did not observe any significant differences in event-free survival by race. In hormone receptor positive, HER2 positive, we did not observe any significant differences in event-free survival among patient race. In hormone receptor negative, HER2 positive patients, we did not observe any statistically significant differences in event-free survival by patient race. It's important to note that among these sub-analyses, our p-value significantly decreased, our power decreased because we had a smaller sample size. For the second part of this analysis, we looked at variations in immune signature expression across racial groups. We know that triple-negative breast cancer is more common in African American women. Additionally, immune signature expression is a predictor of response to chemo and immunotherapy combinations. We wanted to investigate this further, and to do so, we looked at 28 immune-related expression signatures. These expression signatures were related to checkpoint inhibitor targets, such as PD-1 and PD-L1, specific immune cell type specific signatures, and immune cell-related signaling pathway signatures. Given the poor outcomes and survival noted among patients who had residual disease who were also hormone receptor positive, HER2 negative, we looked at gene expression differences in this subgroup. In particular, out of the 28 immune-related expression signatures, the interferon module signature was expressed significantly different. It was significantly higher in expression in Black patients compared to white patients, with a p-value of 0.007. We also looked at 2 additional expression signatures, and these were the ER-PR receptor module and the mitotic score expression signature. Both of these signatures were differentially expressed among patients with residual disease in the hormone receptor positive, HER2 negative subtype. Particularly with patients that were Asian had significantly higher expression of the ER-PR module compared to Black patients. For the mitotic score expression signature, Black patients had significantly higher expression compared to Asian patients. In conclusion, in the I-SPY 2 trial, race is not significantly associated with achievement of pathologic complete response. This indicates that women with high-risk breast cancers are equally likely to experience a survival benefit from receiving targeted neoadjuvant chemotherapy. In our sub-analysis looking at patients who did not achieve pathologic complete response, significant survival disparities were observed, particularly in the hormone receptor positive, HER2 negative breast cancer subtype among Black women, and they had almost double the recurrence risk of white women. This is consistent from earlier reports from the Olopati research team. Finally, in our immune expression signature analysis, the interferon signature was 1 out of 28 immune expression signatures that was differentially expressed among racial groups with the receptor subtype of hormone receptor positive, HER2 negative. We hope that further evaluation into the tumor immune microenvironment will help us figure out the prognostic role of these differences. Our analysis included the following limitations. Women in the I-SPY 2 trial have high-risk breast cancers based on their molecular subtypes. This differs from the general population of women with breast cancer, particularly those with hormone receptor-positive, HER2-negative cancers. Another limitation was the small number of self-reported Black and Asian patients included in our analysis relative to the number of self-reported white patients. However, these demographics reflect the US population racial demographics. Notably, there are 12% of patients in the I-SPY 2 trial who identified as Black. Finally, this analysis did not consider patient socioeconomic factors or comorbidities such as hypertension and diabetes, which are known contributors to disease outcomes in hormone receptor-positive patients. Though our sub-analyses were not highly powered and our p-values were not adjusted for multiplicities, the I-SPY 2 trial is currently ongoing and continually evolving, and we anticipate that future analyses will double in size. I would like to acknowledge my following mentors, Dr. Laura Esserman, Dr. Funmi Olopati, Dr. Michael Campbell, and Dr. Christina Yao for their support and advice throughout this research analysis. I would also like to thank the patients and their families and acknowledge the team of investigators in the I-SPY 2 clinical trial. Thank you.
Thank you, Dr. Kyalwazi, for a very nice presentation. The presentation is now open to questions. Let's start from the floor. Dr. Kaklamani.
Kaklamani, San Antonio. Since our population here is around 60% Hispanics, I'm wondering what the rationale was for combining the Hispanics with the white patients. Did you not have enough numbers? And did you look to see, because we have seen changes or differences in outcomes between Hispanics and whites? Thank you.
Yeah, thank you for your question. So for this analysis, we actually did not focus on ethnicity, and that was just something that we did by design because we wanted to focus on patient racial demographics given the significant disparities that are constantly noted in clinical trials. However, we do have data on ethnicity, and I think that's an important point to consider for future analyses.
Thank you. A lot of questions relate to the observation that non-PCR patients of Black race had worse outcomes in ER-positive, HER2-negative breast cancer. Did you account for endocrine therapy receipt and adherence to endocrine therapy? This is the theme of several questions.
Yeah, that's a great point. We didn't look at endocrine therapy among patients, and obviously that could really affect treatment outcomes, but we do have that data, and we hope to look into that further.
Great. And also another question online is, did you perform multivariable analysis to account for the confounding factors? Were these results based on multivariate analysis or univariate analysis?
So we did conduct multivariate analysis. However, we did not adjust for confounders such as like patient comorbidities or socioeconomic factors in this analysis.
Did you have any oncotype data for the ER-positive patients?
You know, I'm actually not sure about that. I want to say it's present in the database because it's such a robust database, but I'm not sure exactly.
Because it might be nice to determine how the percentage of high-risk luminal A versus luminal B.
Yeah, we definitely looked at luminal subtypes, and we also have the distribution of luminal A and luminal B, particularly among the subtypes.
Yeah, a similar question from online is that the I-SPY screens out of those with low mama print, right? It includes only high mama print patients. Any information or racial difference in the screen out population?
Sorry, can you repeat that?
Any information on racial differences for the population that was screened out because of low mama print?
No, that was something we didn't look at, so I would have to go back and check.
Again, another similar question which we addressed before is whether Black patients had reduced access to endocrine therapy due to economic factors and this caused by higher recurrence rates, but again, that information will be forthcoming. Anybody?
Maybe I can add to,
yeah, go ahead, please.
So, Olopati from Chicago. So I think the point of the genomic assay as a qualifier for I-SPY is that regardless of race, everyone got into I-SPY if we had high-risk breast cancer and they were going to be randomized to different agents in a non-racial manner. So in terms of who had access to even participate in I-SPY, you have to be close to an I-SPY site. So it's very clear that there's less than 1% of patients that are in clinical trials. But when they get into a clinical trial that genomically stratifies, then I think we're equating some of the confounders that really exclude African Americans from getting optimal outcome. So this is the beginning of this type of analysis, and we have to congratulate our medical student for pushing us to look at it, because otherwise we would not have looked at it. So congratulations.
Thank you, Dr. Lapade. And we have a couple minutes. One more question. Did you look at socioeconomic status, and did you adjust for that in the study?
We unfortunately did not adjust for socioeconomic status, and obviously that's a huge thing that should be looked at in future trials. So, but we do have that data. We have a patient advocate group that is specifically working in the I-SPY 2 trial to look at racial differences. And I think one of their focuses is to really hone in on socioeconomic factors as well.
Perfect. Thank you very much. Excellent presentation. A lot of good comments online already for your presentation. Thank you very much.